Okay, so now I'm going to talk about resuscitation. Interesting story. Joe was in Afghanistan same time as I was, and in fact, he was in a place called Shank in 2010. I visited Shank around the time he was there, and then this picture is from Shank in 2014 with the people that were there at the time. So Joe and I have known of each other, but we met for the first time actually at this meeting, which is really nice. So I'm going to talk about resuscitation, but I'm going to talk about it really from the standpoint of trauma, not vomiting patients, diarrhea patients, and all these other kind of patients. I'm really going to focus on the trauma patient. And again, everything I say isn't relative to all patients on the planet. It's primarily relative to trauma patients. So let's start with a typical scenario. Everyone has seen this. 24-year-old male who's at the bar with his girlfriend, drinking heavily, gets in his car, smashes his car, and there he is in the field. In Arizona, he's not cold because it's always hot here pretty much, but EMS comes and they start IVs, and the first thing they do when they start these IVs is they give normal saline. So here in Arizona, is normal saline the most commonly used fluid in the field? Raise your hand if that's true. Okay, most commonly used fluid in the world. I'm going to tell you where it came from. You're going to love this story. Okay, so the fluid is room temperature. The fastest way to make a patient cold is to give them room temperature fluid. It'll cause heat loss, and I'll show you that as well. But now he gets to the trauma bay, and the first thing we do, of course, is undress him. He loses more heat. He's hypotensive. His fast is positive. We send some labs, but in the meantime, of course, we give more room temperature normal saline. So now it's off to the operating room, and the patient's hypotensive, so we're going to give him some blood. And blood is actually colder than the fluid. It's 4 degrees Celsius. That even makes him colder. We start the operation. Our labs that we sent half an hour ago finally come back, and we find out that he's coagulopathic, so now we're going to give some FFP. We ordered a half an hour after he got there. It takes another half hour to thaw it, so it's an hour before we actually give the FFP. And then we give, of course, more normal saline. Okay, so we're going to talk about the importance of coagulopathy, the etiology of it, and then the effects of fluid on essentially the lethal triad, which is what we'll talk about, and also popping clots, which is important as well. So this story I'm going to tell you is not a new story. This is a scene from World War I. In World War I, there was a captain there. His name was Walter Buchanan. He ended up being a physiologist at Harvard. And this is what he said: what is wanted is a fluid that will have the advantages of salt solutions together with the antagonism to state of acidosis. So Walter Buchanan published this paper in JAMA in 1918 saying that normal saline is bad because it makes patients acidotic. But unfortunately, we never listened to him, and 100 years later, we're still doing the same thing. Now, this is where the normal saline came from. The reason we started giving fluid in the first place was because of the cholera epidemic started in 1831. And we had these various kinds of fluid, muriate of soda, carbonate, aqua khalid, that just means hot water, sulfate of potash, and you can see what they were. And believe it or not, the way these fluids were given, either subcutaneously or per rectum. So these poor diarrhea people are coming with cholera, and they're shoving these weird fluids up their butt, which is probably why the mortality was about 90%. Now, along comes Sidney Ringer. Now, Sidney Ringer from the Ringer's lactate solution, this is the guy. Here's the guy. He was a British physiologist. He was supposed to be a great teacher. He was fanatically punctual. This guy was never late to anything. In fact, one time he was almost late to a meeting. He scaled the building, broke the window, and he went right into the meeting because he couldn't be late. But on top of being fanatically punctual and a little bit crazy, he says this comment: first and foremost, you've got to be open-eyed, open-minded, and be honest. So Sidney Ringer decides that the ideal fluid is going to be the fluid that makes the frog heart, isolated frog heart, beat the longest. So he takes these hearts out of frogs and he puts it in a little dish and fills the dish with fluid and sees how long the heart beats for. So he puts the normal saline in there, the thing dilates and stops beating immediately. So now he does a bunch of different fluids, and one day he puts the heart in a fluid and it beats for 3 days. So he said, this is the fluid. We got to have this fluid. So he tries it the next day, doesn't work, tries it the day after that, doesn't work. So he grabs his assistant and he says, what the hell happened 3 days ago? You gave me this fluid, the thing beat for 3 days, and the assistant turns all red. He goes, sir, I'm really sorry, but we ran out of distilled water that day. I had to give you river water from the River Thames. And Sidney Ringer says, aha, it's the stuff in the River Thames that made the heart beat all that time. So he went and analyzed it and found out that there was potassium and calcium in there, and his fluid had potassium and calcium in the same concentration as in the River Thames. And that's where the Ringer's lactate came from, believe it or not. Okay, what about the normal saline? The normal saline came from this guy, Hartog Jacob Hamburger. Hartog Jacob Hamburger was a Dutch physiologist, and he says the ideal fluid is the one with the same freezing point as human serum. That's the one. So he tries all these different sodium chloride concentrations, and he finds out that 0.92% saline has the same freezing point as human serum. That's the fluid. There's no data other than that, and that's why we're still using it today. Now, this man, this poor guy, died penniless, and he's in some unmarked grave somewhere that I don't even know where it is. And despite that fact, everybody uses this fluid all the time, and that's where it came from. Okay. So we know that coagulopathy is bad. This is data from Miami, 6,000 patients. Regardless of how severely injured you are, if you come to the hospital coagulopathic, you're more likely to die. And the difference is greater as you become sicker. So if you have a very high injury severity score, you are almost 100%, your likelihood of death is near 100%. This is very different if you don't present coagulopathic. Coagulopathy is very, very important. So where does it come from in trauma? This is a slide made by one of my residents. He did a great job on this. There are two components to coagulopathy and trauma. The first component is the acute traumatic coagulopathy. That is an endogenous coagulopathy that occurs from trauma and shock. So if you're hit by a train, you have massive trauma, and then you go into shock, you become coagulopathic at the scene. I will show you data that proves this. Okay, this is supposed to be mediated through the protein C pathway. So you're already coagulopathic, and now here comes the EMS guys. They're putting the IVs in, and they're giving the normal saline. The pH of normal saline is around 5. It's a moderately strong acid. Don't we want to avoid acidosis? Why are we pouring a moderately strong acid into our patient? It's at room temperature, and it has no coagulation factors in it. So now we're inducing trauma-induced coagulopathy that does all these things that you see below. It causes a massive inflammatory response. That is why we started describing ARDS in the Vietnam War, because the Vietnam War was largely resuscitated with lactated ringers. And those patients got ARDS. It causes hyperfibrinolysis. It causes the fibrinogen not to function properly. It causes the platelets to be dysfunctional. So now you have a cold, diluted patient who can't make clots, and when they make the clots, it's dissolved. You might as well just give them a massive bolus of heparin. It's about the same. So all of this causes uncontrolled hemorrhage, but on top of all of it as well, you cause vascular permeability, and I'll show you that data. So now the patient swells, and you get organ failure and ARDS. That's what fluid does. Okay, I'm talking about this patient. This is an Afghan national police officer who is voting in April of 2014. There was a big vote in April of 2014. The United States supported this, but people were lining up to vote, and it was a perfect situation for terrorists to shoot them all down. We had 8 guys shot at once that came in. This was one of them, shot in the abdomen, popliteal artery, in the left and the right leg as well. We did damage control surgery, and he ended up surviving, but he got a massive transfusion. All right, so what does that one, if you give that 1 liter of normal saline, what does that do to, how much heat does that cause the person to lose? So don't fall asleep, it's a very simple equation. Heat loss, or Q, equals mass. 1 bag, 1 liter is 1 kilogram. Specific heat of water is 1. That's 1 times 1. The patient's temperature is 37. Room temperature is 25. Therefore, every time you give a liter of fluid at room temperature, you cost that patient 12 kilocalories of energy. 12 kilocalories of energy, what does that equal? Well, that is more than you can do with airway rewarming. If you give a couple of liters, you overcome all of your ability to give back heat. Your patient will get cold if you give them this. It's the fastest way to make them cold, and you cannot compensate for it. If you're going to give fluid, make sure that it's warm. It's very important. The only way to overcome it is either with continuous arterial venous rewarming. You put a catheter in the femoral artery and the catheter in the femoral vein, hook up those catheters to a level 1, and you set up a closed circuit, and you give about 100 kcals per hour that way, or cardiopulmonary bypass, 600 kcals per hour. But you don't want to put your patient on cardiopulmonary bypass because you made them cold with the acidotic normal saline. Now, the coldness is very interesting. The first thing that happens when you send a blood sample in your laboratory, the first thing that happens is your lab warms that blood sample up to 37 degrees Celsius. So if the patient's cold, you don't get to see the effect of hypothermia on coagulation. So this is a study from Harborview where they looked at what actually happens to the prothrombin time if you measure it at decreasing temperatures. And what you see here is at about 35 degrees Celsius, the prothrombin time starts to increase. But what if at the same time you're also diluting the sample? So you see the red line there, you see the combination of the effects of dilution and hypothermia. And what you get when you get less than 35, you see is essentially an anticoagulated patient. Okay, the prothrombin time is very high. Remember, they are already coagulopathic from the injury, and you're just making it worse. Now, you may or may not believe me, but these are real data. And what you see here is as the patient gets colder, there's a direct correlation with mortality. And if the patient's temperature gets down to 32 degrees Celsius, they have a 50% mortality, which I think is very convincing evidence that hypothermia is very, very bad. Okay, this is the most important paper ever published, and any trauma paper that's ever been done, published in 1994 and rapidly forgotten. This was done in Houston, Texas, and what they did was they took patients with torso trauma, penetrating torso trauma, gunshot wounds or stab wounds, and if they were hypotensive with a systolic blood pressure less than 90, if it was an even day, they got 2 large bore IVs and an aggressive crystalloid resuscitation. If it was an odd day, they got their IVs, but they didn't get any fluid until they were in the operating room and the bleeding was controlled. Hypotensive, penetrating trauma patients, no fluid until they were in the operating room and bleeding was controlled. It depends if you came on an even or odd day. That's how it was decided. They did this in 600 patients. And here's what they found. Here's your immediate resuscitation versus the delayed group. You can see the immediate resuscitation group got about 900 cc's of fluid. The delayed group got very little fluid here, so they were very successful in their randomization. Bottom line, if you were in the delayed resuscitation group, you had a 70% survival. If you were in the immediate resuscitation group, you had a 62% survival. That was significantly different. So simply not doing something, not giving the fluid, resulted in a higher survival. The patients also spent less time in the hospital and they had less complications, simply by not giving them fluids, okay? Now here's the labs on arrival. You can see again the immediate group and the delayed group. The immediate group was more anemic, had a lower platelet count, a higher PT, and a higher PTT. That pre-hospital fluid made the patients more anemic and more coagulopathic. They were diluted. Everything I'm saying is proven in these data. Okay, this is the study I was referring to when I was talking about the coagulopathy in the field, done by Flockert. And what he did was he had EMS people go to trauma patients. They put the IV in. When they put the IV in the field, within minutes of injury, they drew blood. And then they resuscitated them in the field, and then they drew blood again. Look at the INR of the on-scene patient within minutes of injury, already 1.3 before any fluid, just from the injury. Now, the median volume of fluid given in this study was 500 cc's, and you can see that 500 cc's, that little bit, half a liter of fluid, already the patients were significantly more coagulopathic when they came to the hospital after that 500 cc's. Okay? Very, very important data. Now, why do we do all this? This is the data from the 70s. This was done by Carrico and Shire's extremely well-respected surgeon scientists. Their model was called a Wiggers model. They did controlled hemorrhage on dogs, and then they resuscitate them. Controlled hemorrhage. Nobody bleeds by controlled hemorrhage. All of the bleeding in trauma patients is uncontrolled hemorrhage. Okay? But what happened was their work, even though it was controlled hemorrhage, it was actually misinterpreted. What they said was, give LR to replace interstitial fluid until the whole blood is available. Guess what? Everybody forgot the until the whole blood is available part. And it became just give LR. Well, I'm a little bit embarrassed because I'm going to show you a study from Fred here that didn't turn out quite the way he expected. So this is Fred's study, and this is about, so we went through this period of time, and I don't know how many of you in the room remember this, but in the mid-90s and early 2000s, there was a theory with trauma patients that you needed to push them to supranormal resuscitation. Okay? The idea was that you increase their oxygen delivery till all the cells are maximally consuming oxygen, And you had to do this. You started with fluid, then you go to dobutamine to increase their cardiac output, then you would give them blood transfusions, and you do all this stuff to make them have supernormal delivery. So this is Fred's paper. Very, very well done paper. Didn't quite get the results that he wanted, I think. But what happened was they found that when they randomized patients to a supernormal group versus a normal resuscitation group, the supernormal group got more fluid. But what did they find? What they found was the patients were more likely to have acute abdominal compartment syndrome, more multiple organ failure, and increased death. And they had a bunch of Michelin people sitting around the ICU with organ failure who were doing very badly. We had the same thing in our ICU. We did the exact same thing where I was at Harborview. We stopped giving this fluid, and all those patients went away. All the organ failure went away. All the air deaths went away. Okay? How many of you have seen something like this? This is the abdominal compartment syndrome. These patients had massive resuscitations. They had massive swelling of their intestines. You couldn't close the abdomen. You were getting fistulas, and you did crazy stuff like put these crazy wound dressings on. We had all kinds of silos and weird dressings to contain the abdomen. Well, we stopped giving the fluid, and all of this went away. So you're seeing there is the Whitman patch there. So that was a patch that you actually Velcroed people Velcroing people. You had one guy stand on either side and pull the Velcro together as tight as you could and then Velcro it down. And then you would do this every day or two. All you had to do was stop giving the fluid. Okay, this is a study from shock trauma. This is an inpatient study. They randomized patients to a goal blood pressure of 70 versus 100. Okay, these are sick patients either going to the operating room or the angiography suite. Now, I want to draw your attention to that top graph. Okay, this is called cyclical hyperresuscitation. They showed it beautifully. I've never seen it better. So notice you see they start at a blood pressure 100. This is a patient randomized to the systolic blood pressure 100 group. They get to 100, what happens? The blood pressure drops. They give some fluid. Blood pressure comes up, and then it drops. Up, down, up, down, up, down, until you stop the bleeding. And then the patient stabilizes. Okay, so I would be in the operating room as a resident, and we would be feverishly putting in stitches, and we're like, oh yeah, we got the bleeding stop. And all of a sudden you look back and there's blood is welling up again. Because we would slow the bleeding down, and the anesthesiologist would catch up, give a bunch of fluid, and now you pop the clots and they bleed more. I had no idea this was happening. All I knew was I was going home with blood in my underwear and socks. And it was very diluted blood, like Kool-Aid. And this is what was happening, cyclical hyperresuscitation. Bottom line in this study, the survival was the same whether you gave a lot of fluid or a little fluid, no difference. Now here's my favorite study, EMS Vs Your Mother. Okay, this was done in Los Angeles, and it compared patients brought to the hospital either by EMS or anyone else like your mother who loves you very much and holds you kindly and kisses you on the face when you're shot in the abdomen. Or perhaps the guy who shoots you puts you in his car and drives you directly to the hospital. Okay? Anyone else but EMS. This study shows for patients with ISS greater than 15 is that you're twice as likely to live if somebody besides EMS takes you to the hospital than if EMS takes you to the hospital. So Avery showed you that if EMS takes you to the hospital, the longer it takes, the more likely you are to die. Well, if anyone else takes you to the hospital, you're more likely to live because guess what? You get there faster. And perhaps some of the things EMS is doing are harmful, like giving fluid and intubating patients. Intubation has been associated with increased mortality. Your mother doesn't intubate you, and because she loves you, she doesn't give you any fluids. Now here's another study done in Canada. They randomized patients to getting IVs versus you don't even get an IV. IV versus no IV. The patients were matched for pre-hospital criteria. They were transported live to the hospital. What this study clearly shows is the patients who don't get an IV get to the hospital faster. If you don't get an IV at all, you get to the hospital faster. And in the bottom table, what you see there is the second most predictive factor for survival is not getting an IV. If you didn't get an IV, you were more than 2 times more likely to survive than if you did get an IV. More than 2 times more likely to survive than if you got an IV. Okay? The only thing that was more predictive is if you got shot. So if you got shot, that was worse. Okay? Clearly, the study shows the longer it takes to get to the hospital, the more likely you are to die. Well, however means you get there, the longer it takes, because you only stop the bleeding of torso trauma in the hospital. Okay? So what about this pop the clot phenomenon? This was actually first described by Bickel, who was the guy who did that study in Houston I showed you. He did this before he did the study on humans. He took 16 pigs, half of them got a regressive fluid resuscitation, half of them got no fluid, just like the Houston people. What did he find? The blood loss was 3 times higher in the pigs that got fluid, and all the pigs who got fluid died. All the pigs who didn't get fluid lived. Okay? So this is a study now done 10 years later by Jill Sondine at the Institute of Surgical Research, and she said, okay, that's interesting. When do you actually pop the clot? So she made a hole in the aorta in a closed abdomen, and then she put drains in the gutters. And then she gave fluid, raised the blood pressure, and measured when did the blood start coming out of the drain. Bottom line, if you look at these graphs, the pig starts to rebleed at a systolic blood pressure around 90. So if the blood pressure remains below 90, the pigs didn't bleed. Okay, so that's the blood pressure where the rebleeding occurs. So this is, again, I showed you this earlier, the Tactical Combat Casualty Care Guidelines. The goal is organ perfusion. You just want a perfused person. How do you measure that? Radial pulse, mental status. If they don't have it, give them fresh whole blood or its equivalent. The last thing you give them, if you don't have anything else and they're dying, then you give the crystalloid. Okay? This is the Joint Theater System Clinical Practice Guideline for damage control resuscitation, one of 44 clinical practice guidelines that govern how we should take care of all injured warfighters. This is the one for bleeding patients. What's the number one most important thing? Stop the bleeding by whatever means possible, whether it's tourniquets, hemostatic dressings, intra-abdominal foam, abdominal tourniquet, hemostatic dressings, whatever you got. Stop the bleeding right now. We know that if the patient presents to the medical treatment facility hypotensive, tachycardic, anemic, and acidotic, they have an 85% chance of getting a massive transfusion. You can measure all those things within a couple of minutes of the arrival of the patient. If the patient has it, the massive transfusion protocol is activated, the blood bank is notified, and the whole blood donors are notified by a loudspeaker that says all warfighters come to the hospital to donate blood, and they come running. The transfusion goal is 1-to-1-to-1, whether it's whole blood or components. Okay, so we wanted to do the exact same thing in the United States through the Resuscitation Outcome Consortium. Could we do this exact same study? Could we treat the patients the same way in the United States? Okay, so this was done, essentially the same resuscitation strategy done all over North America, United States and Canada, 19 EMS units, 10 hospitals in 6 regions of North America. We included blunt or penetrating patients with a systolic blood pressure less than 90 who did not have evidence of a traumatic brain injury. We did not include traumatic brain injury patients. That is not appropriate for hypotensive resuscitation at this point in time. We excluded prisoners, patients with burns, or anybody who got CPR. How did we do this? We put all of these boxes on the rigs. The box either had a 1-liter bag of normal saline in it, or it had 2 250cc bags of normal saline and a 500cc bottle of water for the thirsty medic. All the boxes weighed 1 kilogram. They couldn't tell which was which until they opened it. Okay? If they opened the box and there's a liter bag in there, they got a standard resuscitation, just like ATLS said at the time, 2 liters initial resuscitation, and the blood pressure was maintained at 100. If they open the box and there's 250cc bags of fluid in there, then they only got fluid if their blood pressure was less than 70 or they had no radial pulse, just like TCCC. And then they would get a single bag of fluid, and if the pulse was restored, that's all they got. Okay? The goal blood pressure was 70. That was a randomized trial that we did. The protocol was continued for 2 hours or until hemorrhage was controlled, just like the study from Houston, okay? So the 2 groups were very well matched. We had a standard group and a controlled resuscitation group. Controlled resuscitation, we call this minimal resuscitation. You can see the patients are well matched for age, injury mechanism, injury severity, and all the other criteria, okay? This slide shows you that we were very successful in our randomization. The white bar means the patient got no fluid. And you can see that in the groups that were randomized to controlled resuscitation, the vast majority of the patients got very little fluid. And the group that was randomized to receive resuscitation got fluid. So we had a good separation. Here's the actual data in terms of incremental blood and crystalloid use. you can see that in the field, pre-hospital, patients in the standard group got more than twice as much fluid than in the control group. Once they got to the hospital, patients got, again, another twice as much fluid in the standard group as the control group. But what happened now, the doctors were not limited on how much blood products they could give. Okay, so that by 2 hours after admission, the patients in the groups had gotten the same total amount of fluid, but the patients in the control group had gotten more blood products. And this became a comparison between crystalloid and blood. Crystalloid and blood for initial resuscitation, that's what this became. Okay, bottom line, if you're randomized to the controlled resuscitation group, your mortality was 1/3 of the standard group, and the difference was the greatest in the blunt trauma patients, 3% versus 18% mortality, much higher mortality in the standard resuscitation group. Clearly showing that if you give blood instead of crystalloid early after trauma, you are much more likely to survive. Okay? In terms of secondary outcomes, we looked at renal failure, ARDS, multiple organ failure, and a number of different parameters. There was no difference between the two groups. Okay? So let's take this a step further back. What about giving blood in the field? Should we be giving blood in the field? So this is a nice study done in University of Pittsburgh who looked at patients who received blood in the field versus those that did not. Received blood versus those that did not. This was all done on helicopters. You were either taken directly from the scene or transferred, and they compared patients who got blood versus those that didn't. So for all helicopter transports, if you got blood in the field, you were 5 times more likely to survive. If you got blood in the field versus crystalloid. For scene transports, the difference was even greater. If you got blood in the field, you were 6 times more likely to survive. University of Pittsburgh. Okay, this is from theater. This is from primarily southern Afghanistan. Bastion is where they had the MERT. The MERT is a helicopter system that flies a doctor and a nurse versus our system at the time, which just had a combat medic. Okay, so same thing. This study, they looked at now having both red cells and plasma pre-hospital on the helicopter. Red cells and plasma pre-hospital in the helicopter. The numbers are hard to see. Bottom line is, if you received blood in the field as an injured warfighter, your mortality was 8% versus 20% if you did not. 2 studies, 1 civilian, 1 military, both showing improved survival if you get blood in the field. Okay? If you got blood in the field, you're also more likely to get more blood products at 24 hours, both for red cells and for plasma. Now, this is the proper study. This is a very important study done, a randomized trial, done at 10 centers in the United States, randomizing 1:1:1 versus 1:1:2, plasma to platelets to red cells. Okay, so now this is getting at what is the ratio that we should be giving. 1:1:1 versus 1:1:2, 680 patients randomized, 680 patients followed up. Here's the Kaplan-Meier survival curves. Okay, so the important information is that this randomization 1:1:1 versus 1:1:2 occurred until hemorrhage control was achieved. After that, the doctors could do whatever they want. So what do you see here? You see a very early separation mortality, and the patients who got 1:1:1 were more likely to be alive at 3 hours. Now, after 3 hours, hemorrhage control was achieved, or the patient was dead in most cases, and equal numbers of patients died in both groups, so that 24 hours and 30 days, there was no overall difference in survival. Okay? But look what happens after that randomization is over. So before randomization, the patients get about 1 to 2. During intervention, they get exactly what they were supposed to get. But after randomization, both for plasma and platelets, the patients in the 1:1:2 group got more plasma and more platelets, and the 2 groups started to converge. So it's no surprise that there was no difference at 24 hours or 30 days. Very, very interesting results. Now, this slide is very important. What was the cause of death in hemorrhaging patients? Guess what it was? Number 1 and foremost, exsanguination. Number 2, traumatic brain injury. Now, what about all this other stuff we worry about, right? ARDS, pneumothorax, pulmonary contusion, sepsis, multiple organ failure, stroke, MI, PE. All of those were very rare causes of death. It's all about brain injury, and it's all about exsanguination, with exsanguination and bleeding patients, no surprise, being the number 1 cause of death. And they die at an average time of about 2.6 hours. Okay, let's talk about plasma. There's a lot of different plasma out there. This is very important because you want the right plasma in your hospital. Number one, how do we maintain a 1-to-1 ratio of red cells to plasma in our civilian hospitals? We keep a supply of the FFP thawed. Okay? Once thawed, FFP can be maintained at 1 to 6 degrees Celsius for 5 days. For 5 days. There's minimal degradation of factor function, and this allows you to do a high ratio transfusion. Now here's the factor degradation. It's primary factors 5 and 8. Notice that the anticoagulant factor protein S also decreases. So essentially on day 1 versus day 5, you have the hemostatic capacity of thawed plasma is essentially equivalent. Now this is the stuff you really want, especially if you work in a big hospital. You want liquid plasma. Liquid plasma has never been frozen. Once you freeze and thaw plasma, it loses factor function. This stuff is separated from the red cells and it goes directly to your hospital. In a big center like the ones that we're working at, OHSU, Florida, Toronto, there is no reason to freeze plasma. There is no reason to freeze plasma. It's good for 26 to 28 days. We'll use it all. Between our cardiac surgery, our trauma, our transplant, our OBGYN, vascular, we'll use all the plasma. There's no reason to freeze the plasma. There's minimal factor degradation. It's immediately available. Now all the plasma in your hospital is immediately available. That's what you want. Well, you really want the whole blood, but I'll get to that. Same things degrade, factors 5 and 8. And again, 1 day versus 26-day hemostatic capacity of liquid plasma is the same. If you don't have liquid plasma, you should be banging on the door of your blood bank asking for it. Now, the next thing that we're going to have is dried plasma. The rest of the world has it, or a lot of the rest of the world has it. We don't have it in the United States. In the United States, all the products, there's about 4 companies developing it. All of them are in phase 1 studies going to phase 2. The Germans have been using lyophilized plasma for many years. And they use it in their hospitals just like regular plasma. It's dried plasma. You take the fluid out, you have a powder, and then you reconstitute when you use it. So you could be in your house and you cut yourself shaving, you open the medicine cabinet, there's the lyophilized plasma, you mix it up, give it to yourself, and the bleeding on your face stops. So this is a single donor plasma, so it has to be type compatible. They've done over 200,000 transfusions, no increased risk of any reaction. The Israelis use the German product. The French product is interesting, has not been used as much, but this is a multi-donor product. So it no longer has any type specific, it's a universal donor product. Okay, our U.S. Special Forces use this in theater under an IRB protocol. It can be stored up for 24 hours, and over 1,000 transfusions have been given with no major adverse events. So when you talk about plasma, you think about the ability, the hemostatic capacity, and the ability to correct coagulopathy. But it turns out there are over 1,000 proteins in plasma, some of them of which we know what they do and some we do not. They are biologically active and they have a lot of function. They suppress dysfunctional inflammation, they decrease endothelial permeability, and they rebuild the glycocalyx. So plasma is a drug that has a lot of effects. So we know this is the endotheliopathy of trauma. This is what happens to blood vessels and lymphatics in trauma patients. These are normal blood vessels and lymphatics. They don't normally leak high molecular weight compounds like albumin. But if you have trauma, the cells shrink and now they start to become permeable, okay? If you give the crystalloid, you will exacerbate this vascular permeability and more fluid will leak. If you give the plasma, you'll restore endothelial integrity and the glycocalyx. And here's the actual data. This is looking at the glycocalyx. You can see on your right, the sham has a normal glycocalyx. You do hemorrhagic shock, you start to lose integrity of the glycocalyx. You give LR, it gets worse. You give plasma, you start to recreate the integrity of the glycocalyx. More going on than just coagulopathy. Here's a hemorrhagic shock model in mice, controlled hemorrhage. And what it shows is that just the hemorrhage itself causes an intense inflammation in the lungs. If you give lactated ringers, it gets worse. That's why you got ARDS in Vietnam. If you give plasma, you prevent that inflammation and you don't get the ARDS. Here's the same thing showing with fluid having an increased permeability in the lung versus FFP where you don't get the permeability. Okay, I'm going to talk briefly about whole blood. This is the patient I personally gave the most whole blood to. This is at Shank. This is a guy with a gunshot wound in the abdomen. We took out his spleen, half his pancreas, and his kidney in about 20 minutes. It's nice when two attendings get to operate together. I have to go to Afghanistan to do that. It's fun. I like operating with residents too, but it's really fun when you have two attendings and they know what they're doing. You can do all that stuff really fast. So here again are the medical records. You can see what his massive transfusion was, exactly 1-to-1, 21 units of whole blood. His operation is on the left side. You can't quite see it, but it says exactly what we did in the operation. Okay, so what about type whole blood? Here's the problem. The universal donor for red cells is O. The universal donor for plasma is AB. So what's the universal donor for whole blood? Okay, so it turns out, based on work done in theater and in Pittsburgh, that type O is a universal donor for fresh whole blood. Here's a study of patients, combat casualties, receiving fresh whole blood, equally distributed. Half were type specific, half was O blood given to non-O patients, and there was no difference in mortality and no transfusion reactions were found. So type O blood appears to be a universal donor. So let's talk about fresh whole blood. Probably in the United States, we're never going to have real fresh whole blood. Fresh whole blood means, for the most part, you take it out of one person, you give it to the other. In theater, it's still warm when you give it, because you get it within an hour. Now, the definition for warm fresh whole blood is transfused immediately or stored up to 8 hours at 22 degrees Celsius. It can be stored an additional 24 hours at 4 degrees Celsius. What we are having in the United States is cold stored liquid whole blood, which is stored at 1 to 6 degrees Celsius. It's fresh if it's transfused within 48 hours. It can be stored, depending on what it's stored in, it can be stored up to either 21 days or 35 days. Maximum storage time. So here's a very nice study done in Pittsburgh. The donors were male. They used group O positive units. Okay, so women of childbearing age were not involved in this study. They were leukoreduced and platelet sparing, meaning that you used a filter to take out the white cells and they still had the platelets in there. They were stored at 1 degree to 6 degrees Celsius for 21 days, and this was low titer for A and B. Low titer for A and B means that you can give it to a patient who is either AB, A, or B, and it was stored in an ED refrigerator. So they had male trauma patients receiving these transfusions, 27 non-group O, 17 group O, up to 2 units were received, and there was no adverse events noted related to the blood transfusion. And here's a bunch of lab tests. They looked at haptoglobin, bilirubin, LDH, creatinine, and potassium, all products of a transfusion reaction, and they were the same whether the patients were O or not O. So it does appear, again, to be safe to give type O whole blood as a universal donor. Why don't we use it? Well, it turns out that if you take the whole blood and put it into its components, you can store a lot of it longer. The red cells for 42 days, the cryo and FFP for 1 year. So it's more cost effective to put it into its components. But it does not make sense to take blood, separate it to its components, and then give a 1-to-1-to-1 back. You should have 2 blood banks. One, which is a massive transfusion blood bank with whole blood, and then the components for all the other patients that might need a couple units FFP, maybe some platelets, etc. Okay? Now, last thing I'm going to talk about, very interesting, brand new area of study. What about the qualities of the donor? Do the qualities of the donor have an effect on the recipient? Very, very interesting, okay? So what do you see on the right? It turns out that the younger the donor is, and these are 6-unit transfusions, the younger the donor, the higher the mortality in the recipient. And the older the donor, the lower the mortality. Nobody knows why this is. There's 2 studies that show this now. It's not definitive. Now, what does the other graph show? If the donor is female, the recipient is more likely to die. It's a fact. You can see the data. Those are the data. So, this is sort of preliminary, but the characteristics of the donor may be very important. Now, here's the ultimate donor study. Okay? These are 2 rats, and you sew their blood supplies together so they share a common blood supply. It's called parabiosis. Now, if you do this with an old rat and a young rat, what happens is the old rat starts to be rejuvenated. They have axonal regeneration, they have increased muscle component production, and you can clearly see a regeneration of tissue with rejuvenation in the older rat. Guess what happens to the younger rat? They get old. Just like vampires and Bram Stoker, except you're not sucking the blood, you're giving it. So this has generated a whole bunch of studies. In Stanford, they're looking at Alzheimer's patients and transfusing the plasma of young people to see if they can reverse Alzheimer's. So this is very exciting. Maybe you don't need to give all the blood. Maybe there's a few proteins in that plasma. Remember I said there's 1,000 proteins in plasma? Maybe we can find the proteins that do these things, some beneficial, give the beneficial proteins, take out the bad proteins, and we can make a drug out of plasma that rejuvenates people and makes you do better after transfusion. All very, very exciting future stuff. So what can we say? Fluids are bad for hemorrhaging trauma patients. They delay transport, they exacerbate coagulopathy, they pop the clot, and they increase mortality. Pre-hospital blood is being increasingly available. We need to study it more. It may save lives. The benefits of plasma go way beyond coagulopathy, and everyone in this room is going to be using whole blood in the near future. I guarantee it. Thank you.